Welcome to SARC Talk Journal Club, where we take a closer look at the research shaping the future of sarcoma care. In each episode, we'll discuss recently published studies, break down the findings, and explore what they mean for clinicians, researchers, patients, and advocates. Along the way, we'll be joined by experts from across the sarcoma community and sometimes even the authors behind the research. Whether you're keeping up with the latest science or looking to better understand the evidence driving sarcoma care, we're glad you're here.
Welcome to SARC Talk Journal Club, episode number 2. Today I'm here with our co-host, Dr. Catherine Wilbur, a medical oncologist, sarcoma physician over at Johns Hopkins. And today our second journal club is on Pimicotinib versus placebo for tenosynovial giant cell tumor, or the maneuver study. And we'll have Dr. Wilbur walk through the journal club. Welcome, Dr. Wilbur.
Thank you. Excited for our second episode. So first, I'll go through some background on tenosynovial giant cell tumor. This is a rare, locally aggressive tumor. It arises predominantly in the synovium of joints, the bursa, the tendon sheath. It causes significant joint pain, swelling, stiffness, really limited mobility for patients. And it's really sort of that local, those local symptoms that can become quite debilitating for patients. Generally, surgical resection, when it's feasible, is the standard of care. However, we do see fairly high recurrence rates for the diffuse subtype. And there are two different subtypes of TGCT, the localized and then diffuse. And this tumor is characterized by an overexpression of CSF1, and that really recruits CSF1R positive inflammatory cells, which do end up comprising most of the tumor. In terms of the prior therapies, pexidartinib through the Enliven trial was approved back by the FDA in 2019. That objective response rate for pexidartinib, 39%. But with it comes the risk of fatal hepatotoxicity. And so there is a REMS kind of monitoring that is required for this medication. It is twice daily dosing. There are dietary restrictions. You do need to eat a low-fat meal when taking pexidartinib. And then in terms of side effects, aside from the hepatotoxicity, we do see skin and hair hypopigmentation. Last year, we also saw vimseltinib, which was based on the MOTION trial. That objective response rate was 40% by RESIST. The difference between the medications in the dosing is that vimseltinib is a twice weekly dosing, and that within that study, they did not see the severe hepatotoxicity. However, that trial was a little bit more limited in terms of where it was done. So it was predominantly in the United States and in Europe. As the authors were kind of presenting this trial, they did point out that there are less than half of patients who have an objective response to available therapies. There is limited global availability and sort of underrepresentation of Asian patients in the two prior trials mentioned. And then really that need for sort of a once a day medication, that's maybe a bit more highly selective and might have broader efficacy. So that led to the maneuver study. And so we'll just go briefly through this study design schema. Patients were randomized. This was a phase 3 trial. Patients were randomized 2-to-1 to Pimicotinib or placebo. There were 3 different parts of this trial. So part 1 was a double-blinded that went on for 24 weeks. And so patients were, again, randomized 2-to-1 to receive Pimicotinib at 50 milligrams. It was once daily, or placebo that they also took once daily. We'll get into the endpoints in a little bit, but they were looking at the primary endpoint of using MRIs at week 25. The second part of this trial, which we won't get into and wasn't reported, was the open label portion of it. And then part 3 is sort of the long-term extension that's ongoing. When we think about the key eligibility criteria, patients needed to be 18 years or older and then have histologically confirmed TGCT. Their tumors needed to be unresectable, and they did have to have symptomatic tumors. So they were given sort of a scale in order to kind of grade their symptoms, and their pain or stiffness did need to be a 4 or higher on a scale of 10. And then they did need measurable disease, and they were not allowed to enroll if they had had prior CSF1R inhibitors. There were 40 hospitals that were participating in this trial across 3 regions, so within China, Europe, and North America. The enrollment took place from April of 2023 through March of 2024. Majority of the centers were in China, so 23 of them. So patients were stratified kind of by location, whether they were predominantly in China or not, or outside of China. The primary endpoint was objective response rate at week 25 by blinded independent review committee per RECIST. The secondary endpoints were objective response rate by tumor volume score. And then they also looked at mean change in sort of the range of motion, the stiffness, pain, and physical function using sort of a number of different scales. And then they looked at health-related quality of life as well as a secondary endpoint.
Dr. Wilbur, as you think about this, both the Enliven trial and the Motion trial did use overall response at week 24, but, the same in this ballpark.
Yeah.
Can you kind of say, is this an appropriate endpoint? Because now you have 3 major randomized studies using overall response rate at week 25, 24.
Yeah, I think it is a good endpoint. I mean, it certainly was helpful that this was consistent right throughout, and really gives us a sense of, that sort of tumor change that we're seeing, right? Especially for a tumor that, is more damaging sort of locally, right? Doesn't tend to metastasize. And so I do think that was a fair endpoint.
Yeah. And this study, like many of the others, did use a blinded independent radiology central review. And, a lot of times the investigators might think differently, but ultimately the decision whether they were responding or not was by blinded. Can you comment on that?
Yeah, absolutely. So, there's basically sort of an independent third party that will look at this and kind of give us that objective, won't know what the patient is being treated with, and will kind of be able to provide that sort of objective view, if you will.
There are a little bit of physical changes that goes on sometimes that you might know if someone's really on treatment or not. However, they did use RECIST, and many of us, when you're following joints or lumps around synovium, it's kind of a hard thing. Can you comment on, and they kind of comment in their paper too, on the use of MR and RECIST 1.1 as their primary endpoint?
Yes, they did comment on that a bit, and just thought that it would kind of be the overall sort of best way to assess as they were looking at this sort of more objective. Was there something else you had in mind?
Well, to that point, there are other scorings that you could technically use, but, the easiest, most reproducible ones that we can do is just, straightforward RECIST 1.1. There's no 3D mapping or tumor volume around this area. Those are all exploratory in nature. But, this is something that most clinicians know how to do and measure. So the endpoint was pretty straightforward. And as you said, there's a lot of secondary endpoints, and we'll get into that.
So as we look at the results, there were a total of 94 patients that were enrolled. So 63 patients received Pimicotinib and 31 patients received placebo. Overall, it was, well balanced. The age was fairly similar. It was median age of 41 within the treatment group and 36 within the placebo. We did see a slight predominance of females, so 71% female in the Pimicotinib versus 61% in placebo. Good performance status of ECOG of 0 or 1 for both. And then we did see that there were predominantly, or just slightly over 50% Asian patients. So 51% in the Pimicotinib, 52% within the placebo. And then looking at sort of the geography of where they came from, 49%, because 48% in the total were from China, 30% Europe, 22% within North America. Many of these patients, most of these patients were actually treatment naive. So 94% were treatment naive in the total population. 97% were treatment naive within the Pimicotinib group. And then just slightly over half had prior surgery. So 59% in the Pimicotinib, 61% in the placebo group. And then when we look at sort of the baseline symptom score, the worst pain, the median score for both groups was a 4.8. Stiffness was pretty similar. It was 5.3 in the Pimicotinib group and then 5.6 in the placebo group. And then the relative range of motion, sort of what patients had anticipated, was 70.6% within the Pimicotinib, 66% within the placebo group. So this study did meet its primary endpoint of objective response rate at 25 weeks. The objective response rate was 54%, 34 of 63 patients in the Pimicotinib group. And then the objective response rate was 3%. So in the placebo group. So one patient out of the 31 did have an objective response. The slides are sort of, show this very nice waterfall plot here where we can see those responses. And then when the authors did break it down by a patient subgroup. And so they looked at those objective response rates based on tumor location, disease location, region. And I think what was interesting is just, slight differences between like the region. So China, the absolute difference between the Pimicotinib and the placebo group was 65%. Side of China, that absolute difference was 38%. And then in terms of sort of the number of previous surgeries, those who had one prior surgery or greater within the Pimicotinib group, that was 59% of patients, so 22 out of 37, but that absolute difference was 59%.
You would probably say that almost all known characteristics benefited from Pimicotinib compared to placebo. There was no group that didn't. And what you're saying is there might be a little bit of variation of how much they benefited, but they all benefited. You're right.
Yeah, absolutely. Yeah, every patient subgroup did benefit.
Yeah.
And then we had sort of mentioned the secondary endpoints and sort of these functional outcomes. And so in terms of sort of the range of motion, patients felt that got better by about 15%. They did feel that the stiffness decreased as well. Pain had decreased when we looked at their responses by 2.3, and then pain was measured in two different ways. And so we saw that their responses were more significant, had significantly improved on treatment. Really, what we were seeing is that these improvements, at this 25-week mark, were pretty significant, right? So in terms of just sort of these quality of life measures and symptom, were present early. And then they did note that fewer narcotic users were apparent in the group that was receiving the Pimicotinib. So overall, this was well tolerated. We did see that all of the patients who were enrolled did have a treatment-related adverse event, but only 8% of patients required a dose reduction. We did see that 35% of patients did have a treatment-related adverse event that was graded as a 3 or 4. Only 2% of patients, though, ended up discontinuing the medication. But within study, they were allowed to interrupt the dose. And so the dose was ultimately interrupted in about 54%. I think what's notable, authors break it down by sort of lab abnormalities and then clinical adverse events. So we do see that CPK was increased, within the Pimicotinib group in about 71% of patients. They did measure, LDH and AST. And so those were also increased in 57 and 54% of patients, respectively. As we look at the clinical adverse events, we did see higher rates of pruritus, so 52% of patients, but only 3% of patients had a grade 3 or 4. We did see facial edema in 48% of patients in the treatment group, and then rash. So we saw rash in about 35% of patients, but only 3% who had a grade 3 or grade 4. We did see hypertension as well that was there, and some arthralgias. Otherwise, sort of what we would expect in terms of some fatigue, some nausea, headache, insomnia.
So these are kind of the typical side effects, Dr. Wilbur, that we would typically expect with somebody on a CSF1 inhibitor type of a thing?
We do. I would say the one important difference, we didn't see the high rates of hepatotoxicity that were seen in pexidartinib.
Got it.
And then I would say the pruritus and rash, we certainly saw as sort of expected. So I think the key takeaways, there was efficacy for this treatment. So objective response rate of 54%. It certainly is difficult to compare across trials, right, between the pexidartinib and vimseltinib. But we did see within pexidartinib, that objective response rate of 39% and vimseltinib of 40%. But within this trial, we did see early and durable responses. It was consistent against all of our subgroups. And there were meaningful improvements in pain, in stiffness, in range of motion, and quality of life. From a safety standpoint, we did not see hepatotoxicity or that significant liver injury or the hypopigmentation. Overall, there were low rates of dose reduction and discontinuation rate. this, patient population certainly was generalizable in terms of sort of the number of the patient population that was included. And then the other nice thing about this drug is that it is once daily dosing. So without that food restriction. So it certainly can be convenient for sort of patients who, do better with taking a pill just once a day.
Absolutely. So there are some questions that you have as well.
Yep, absolutely. I think the big question, right, is sort of that optimal duration of treatment. Like, how long should we keep these patients on? Are we able to stop, to restart? Can we use treatment holidays for these patients? And so I think those are certainly questions that need to be answered. And then, I think the other question is of treatment sequencing. What is really the role after prior surgeries? How would these patients respond after prior imatinib or other CSF1R inhibitors? I think then looking at sort of the applicability to sort of the broader population, most of these patients enrolled did have the diffuse subtype. So, would we see that efficacy sort of in the localized TGCT? There were 12% of patients have localized TGCT in the trial. And then certainly I think, given this median age, is the question of impact on fertility and on family planning in our younger patients. I think we are waiting for parts 2 and 3, which are ongoing. So sort of that long-term efficacy and durability. And then, of course, always having that real world data to address, to dosing, sequencing, access, et cetera.
Absolutely. So Dr. Wilbur, we have now 3 agents that have activity. Mm-hmm. We have pexidartinib, we have vimseltinib, and now we have Pimicotinib. Kind of how do you start to see when you approach patients that need systemic therapy for their tenosynovial giant cell tumor? How do you start to discuss this with your patient?
Yeah, absolutely. I think the exciting thing is that, we do have approved treatments for TGCT, right? And the fact that we have options is really exciting within the field. I think, as we're thinking about how do we choose, right? I certainly think that sort of the dosing will be important. There are patients who, might do better with, once a day or twice weekly or even twice a day. And then I think, the side effect profile is going to be really important here. Certainly concern about, hepatotoxicity, sort of REMS monitoring for some of our other choices here.
Absolutely. As we're told not to go cross-study things, this study, at least in the more modern era now, modern meaning as when it was published in 2026 in Lancet, it had the highest response rate, but there could be many other factors in here. So as we start to look at this, I think Dr. Ju and the investigators that did maneuver study for Pimicotinib versus placebo for tenosynovial giant cell tumor, which is both in China, Europe, and the US, it's very broad, does show activity. And they did publish their article in Lancet 2026. And any final thoughts, Dr. Wilbur, on this use of Pimicotinib for tenosynovial giant cell tumor? I'm always saying PVNS, but I have to use the right term now. Tenosynovial giant cell tumor.
Yeah, absolutely. No, I think it's great. We've got another option. We're seeing it used in a broader, patient population, as you mentioned, slightly different dosing. And so I think, it's great here. I think we're hopefully anticipating, approval and having this option for patients.
Yep. Absolutely. So again, thank you for listening to episode number 2. If you have any questions or comments of SARC Talk Journal Club, please let us know. And we look forward to our next episode, number 3.
Thank you for listening to SARC Talk Journal Club. If there's a publication you would like us to review or a question you would like us to address, we would love to hear from you. Leave a comment or email sarctalk@sarctrials.org. Be sure to follow the podcast, leave a review, and share this episode with others in the sarcoma community.